Hello everyone, my name is Katie. I'm currently a staff nurse working in gynecology, studying a PGC in medical ultrasound. Today I'm going to talk about an abnormal case study exploring molar pregnancy and ultrasound. The Royal College of Gynecologists describes molar pregnancy as something that occurs due to defective fertilisation. Molar pregnancies can be subdivided into complete mole and partial mole. This is based on genetic and histopathological features. Complete moles usually arise as a consequence of duplication of a single spermatozoa following fertilization of an empty ovum. A partial molar occurs in most cases when an ovum is fertilized by two spermatozoa. The difference between partial and complete mole is that complete molars do not develop any fetal tissue, and partial molars usually have a gestation sac yolk-sac and fetal pole, in some cases a fetal heartbeat. Both complete and partial moles are associated with a risk of development of gestational trophoblastic tumours, the risk being greater in complete moles. Molar pregnancies affect 1 in 700. The UK has an effective registration and treatment programme. The Royal College of Gynecology states there is a high cure rate of 98 to 100% and a low chemotherapy rate of 5 to 8% of molar pregnancies. The case today I'm going to discuss is patient A. She's a 20-year-old who is pregnant for the first time, has no medical history, and has a regular menstrual cycle. Her last menstrual cycle suggested gestation of 9 weeks and 4 days. The patient attended the early pregnancy assessment unit due to experiencing some brown vaginal loss. The NICE Guidelines 2019 states all women should have access to an early pregnancy assessment unit 7 days a week. The patient is first assessed by the nurse, who then gives the relevant information to the sonographer. The sonographer should use effective communication to gain rapport and give an explanation of the procedure, the risks and benefits, in order to gain valid consent. This should be done in a timely and appropriate manner. The women should be cared for with respect, dignity, ensuring adequate privacy, as per the BMIS and the Royal College of Gynecologists guidelines. The patient was scanned transabdominally as per local guidelines, as suggested gestation was 9 weeks and 4 days. Unfortunately, the sonographer could not see a 9-week, 4-day pregnancy through the abdomen, so therefore a transvaginal ultrasound was then performed. The scan report stated a bulky uterus containing a multicystic area of 95 by 100 by 60 millimeters. This was suggestive of complete molar pregnancy. The area covered the entirety of the uterine cavity, with a minimum of 5 millimeters of myometrium being seen. The ovary and the adnexa had no abnormalities detected, and there was no free fluid in the pouch of Douglas. As you can see on image 1 on the poster, this shows a transverse view of the uterus, and image 2 shows a longitudinal view. The appearances show a classic complete molar pregnancy, as you can see a large mass in the uterine cavity with small cystic structures resembling a sandstorm effect. This characteristic was first described by Donald in the 1960s. The patient was given the diagnosis by the sonographer. A sonographer has the ability to give bad news in a way which is empathetic to the patient, whilst giving the facts of the findings, not using jargon that may confuse the patient. A nursing journal in 2018 described effective communication as the ability to listen, to convey interest, to give compassion, give knowledge and information. The patient consented to a surgical evacuation of the uterus to remove the molar pregnancy. The surgery was successful. The gold standard for confirmation of molar pregnancy is histological examination. The patient consented to have the histology testing, which confirmed a molar pregnancy. The patient was then referred to Western Park's Trophoblastic Centre for follow-up. Follow-up entails beta-HCG blood tests weekly up to 56 days post-surgical evacuation. If the pregnancy hormone level is negative before the 56 days are complete, the patient is discharged. However, if the pregnancy hormone level is still positive after the 56 days, they may need chemotherapy treatment. I have searched for relevant literature regarding molar pregnancy and ultrasound. I found 3 studies of interest. One observational study by Ross et al. 2018, a retrospective review by Sebre et al. 2001, and a cohort study by Jones et al. 2005. These studies explored the detection of molar pregnancies by initial ultrasound scan, mostly in the first trimester of pregnancy. The timescale and participant numbers differed. However, two studies results showed detection by initial ultrasound scan had 50% success rate. All 3 studies looked at the sonographic appearance of molar pregnancies, which were mostly similar, using different descriptive words. All 3 studies agreed that partial molar pregnancies were complex and challenging to detect than complete moles. A complete mole can be described as an intrauterine mass with multiple solescent spaces which are grape-like or described as a sandstorm effect with no anembryonic tissue present. A partial molar is more complex in appearance, as in most cases a gestation yolk sac and fetal pole will be present, and in some cases a fetal heartbeat. Partial molars are easy to detect in the second trimester, as multiple echo-free areas appear in the chorion and sometimes in the amniotic cavity. On the poster images of a partial molar shows a first trimester pregnancy. A fetal pole is present in the gestation sac. In the uterine cavity are areas of multi-echo-free areas. The appearance of this particular image quite clearly shows the echo areas which detect partial molar. However, in a large number of cases, the appearances appear more subtle, therefore making it harder to detect. The study by Sebre et al. 2001 shows the rate of which sonographers do not detect a molar pregnancy and are diagnosed as miscarriages or embryonic pregnancies. Their study showed 67% of cases were missed and only 34% were detected. However, this study was done in 2001, which shows us that the detection rate has increased and sonographers have better awareness of molar pregnancies. Also, equipment may have attributed to this, with the use of transvaginal probes giving better lateral resolution. A sonographer's role in detecting molar pregnancy is to be aware and check for subtle changes, as well as obvious in order to increase detection rates. Their role is also the care of the patient to ensure they understand the procedure, including risks and benefits, and to ease patients' anxiety and woes, and give bad news in a way of empathy and compassion, ensuring the patient understands the scan results. In conclusion, diagnosing molar pregnancies sonographically remains a laborious task, especially for diagnosing a partial molar. However, the studies show 50% of molar pregnancies are detected, which is a 15% increase since the study in 2001. Further awareness, research and education is needed for sonographers to increase that detection rate in the future.